Well, hello, everyone. Welcome to our webinar. We will be reviewing temperature during the perioperative period, and this will be led by Dr. Joseph M. Hendricks. I am Dr. Catherine Tobin, and I'm an associate professor at MUSC, the Medical University of South Carolina in Charleston, and I'm also the chair of the Education Committee for SAMBA. I'll be moderating this webinar. For those of you who are not SAMBA members, please consider joining the society, as it offers many benefits to the members, including a discount at SAMBA's upcoming annual meeting this May. Also, you can visit our website to see the benefits of membership at www.sambahq.org. A few quick housekeeping notes for today. Please note the webinar is listen only, and in the upper right of your computer screen on the control panel, you'll see a chat box, and feel free to put your questions in that chat box. There's also a question box where you can enter these, and I'll be reviewing these, and I can ask Max these questions at the end. You can type a question or comment and submit it any time during the presentation. And as I mentioned, at the end, we'll have a Q&A at the end of the presentation. All right, so now to introduce Dr. Hendricks. So Dr. Hendricks is an assistant professor with the Department of Anesthesiology and Pain Management at the University of Texas, Southwestern in Dallas. He has been on staff since 2012, and his practice is primarily focused on ambulatory anesthesia, especially in complicated patients who aren't suited to the University Outpatient Surgical Center. All right, Dr. Hendricks, let's get it started.
Okay, thank you very much. I'd like to thank SAMBA for the opportunity to give this presentation today. Very much appreciate it. So we're going to be talking about, obviously, temperature during the perioperative period. It's a topic that I find to be quite interesting, and I find very interesting how confrontational it can sometimes be in a perioperative, peri-procedure setting. And the perception, I think, is more that perhaps this is the way it's always been, perhaps in operating rooms. They're supposed to be really cold, and so therefore they should always be really cold. It's quite interesting, the I don't know, conflict or resistance, I should say, to the idea that temperature is very important for patients during anesthesia. So for this sort of a presentation, it's going to be starting, of course, with our objectives. Going to go over a little bit of background, as dry as that might be, because it's quite important to know some of those factors that are important to understand when you're trying to prevent the development of hypothermia, as well as to reverse the hypothermia. The physiology of thermoregulation, hypothermia during the perioperative period, managing normothermia during the perioperative period, and coming to some conclusions. So we're just trying to get to the point of sort of helping to understand the physiology of thermoregulation, the effects of anesthesia on thermoregulation, the importance of perioperative normothermia, measures and guidelines for perioperative temperature management. So as is pretty straightforward, surgery in general is going to be pretty stressful on the body. And so this is going to bring about all sorts of major physiological changes that tend to come about during surgery. There are lots of physiological parameters that are going to get affected by anesthesia, but one of those is going to be temperature. And hypothermia during the perioperative period is a common complication leading to some fairly important adverse effects. In fact, the data would tend to suggest that post-anesthesia, PACU, recovery room, however you wish to define it, despite being within SCIP guidelines, within CMS requirements, within being emphasized seemingly on a pretty significant level at a regulatory level, you still find that at least per most studies and most evaluations that almost 50% of patients are coming into the PACU, coming into recovery in a hypothermic state, despite the regulatory discussions of these issues. So I guess some pretty basic, straightforward definitions to try to keep us all on the same sort of a level. So if we're talking about the normothermic state, basically what we're trying to get at is to a level of core body temperature where the cells are neither having reduced activity or increased activity just due to the thermal stress. That's really the key component that you're looking at here. So when you talk about a body core temperature less than 36, the important point about that is that that is the level in a non-anesthetized person at which the body tends to want to respond to do something to try to get the temperature up. By the same token, the body core temperature, once it gets above 37.5 degrees Celsius, that's when the body tends to respond to try to get the body core temperature down. Clearly, it's going to become life-threatening as it goes higher and higher in a hypothermic state. So what is thermoregulation? So it's essentially just the way the body tends to maintain the thermal stress at a homeostatic state, a stable state for body temperature. And it happens through 3 phases, not terribly exciting, but fairly important, because afferent input, central regulation, and efferent are all important, and all important because of the effects of the perioperative and anesthetic state. So what are we talking about with afferent input? Well, it's very simple. It's just how the temperature and the thermal stress is being perceived by the body. And specifically, usually it's from exterior, but it could also be from interior at the central core. And so what it is it's just going back into the central nervous system in order to essentially initiate some sort of a response at the hypothalamus. This central regulation occurs automatically, doesn't require any sort of higher brain input, and promotes behavioral responses output that will tend to cause you to want to either, conserve heat or try to increase the heat. The importance of all of that is clearly under an anesthetic state that is no longer able to be done with any capacity by the patient because of the anesthetic state. They can't have any behavioral responses anymore, and even if they did, they wouldn't be able to respond appropriately anyway. More importantly, they won't be able to perceive any sort of a thermal stress or thermal deficit appropriately, and even if they could respond, they wouldn't respond appropriately. But perhaps the most important part of the equation is the efferent response and the inability of the patient to be able to respond appropriately in an autonomic way to any sort of a thermal stress. And that's because the anesthesia by itself, the anesthetic state by itself, is going to inhibit that ability to respond. So here you have some efferent responses, fairly straightforward. You can have vasoconstriction. Obviously, if it's, a cold environment, you can have non-shivering thermogenesis, shivering, again in a cold environment. You can have vasodilation and sweating, again, in a warm environment. And those thresholds tend to change and vary based upon all sorts of factors. But again, in a non-anesthetized patient, that is what will affect some of the efferent responses. It will still be important in the anesthetic state, but much less so. The range at which this autonomic defense system or thermal response system, however you wish to look at the terminology, that is generally referred to as the interthreshold range. And it's, again, a testament to the human body and its resiliency in terms of how quickly and how aggressively it will respond in a non-anesthetized state. And so it's essentially the same as with pH, right? Because pH you don't have to change pH very much, and the body will respond, the human body will respond quite quickly because pH is controlled in a very, very narrow margin. And the same with the core body temperature in a non-anesthetized state. However, under general anesthesia, but in reality, any sort of anesthetic state, those effectors are no longer going to be engaged until that change has occurred over a much wider range. And by that point, the negative effects of the thermal load or the lack of heat is going to be the problem. So these are some excellent studies, and I have the references right down there because they beautifully illustrate several different types of anesthetic or analgesic agents, all of which are essentially showing the exact same problem, and more importantly, showing the problem in the direction of hypothermia. So what I mean by that is that if you look at these graphs, what you're seeing is that with increasing concentrations of various anesthetic agents, that you have decreased effector responses, right? So you got sweating, you got vasoconstriction, and you got shivering, okay? But if you look at the magnitude of the change for sweating, it's relatively not not very significant. But for constriction and for shivering, it's quite significant. And so that's why it tends to be more of an issue of hypothermia than hyperthermia, because those specific effector responses are have such a greater dampening during the course of an anesthetic state. So hypothermia during the perioperative period. Again, when under anesthesia, the body is relying solely on autonomic responses and, unfortunately or fortunately, depending on, I guess, the external temperature management involved, for thermoregulation. So with those autonomic responses being altered and being increased in terms of the bandwidth at which they will then respond, essentially what the patient is left with is, at that point, external temperature management, aka you and me, because that's going to be the most important factor when the patient is under an anesthetic state. So, you have some of these items up here of causes or mechanisms, however you want to really look at it, of how you can have hypothermia under anesthesia. Obviously, OR temperature, cold surfaces, cold fluid, skin preparation, etc. Cold IV fluids. Again, in an ambulatory setting, I'm not sure how many times you're going to be transfusing blood in that sort of a setting, but the point being is that potentially if you're infusing cold fluids, that could potentially decrease the body temperature, but as we'll see, that's really not necessarily what you should be most concerned about in a general operative setting. Anesthesia. Probably the biggest and the most important right off the bat is anesthesia-induced redistribution of heat from the core to the periphery. And that's really going to be the case with virtually all anesthetics and almost all anesthetic techniques. And that's really the problem that people, I don't think, have a great appreciation for as to what that does for your ability to manage a patient's core temperature in that setting. Surgical technique, of course, exposure of body cavity, obviously duration of surgery, but again, in an ambulatory setting, that's probably less of a concern in a general sense. So this, sort of a graph or slide, I think is quite important, more for the appreciation of what the problems are. People are, I think, under the assumption that if, we're just doing a regional case, or we're just doing regional with sedation or something like that, that means that, we're probably not going to have to worry about hypothermia. That's not really true. But if you want to think about what's going to be the worst of all in terms of your risk of hypothermia, it's going to be the combined regional and general anesthetic type of a case, which is kind of a common, generally speaking, kind of a common sort of a modality that tends to be used in an ambulatory setting. So, what are the ways we're going to end up losing heat during surgery? Well, you got your 4 basic ones, which pretty straightforward. Conduction, despite all the pads or blankets or foam mattresses and whatnot that is put underneath the patient, conduction, generally speaking, is a pretty negligible source of heat loss in the operative setting, okay? In the operative setting. Now, evaporation. So there's a lot of, intense work done about various humidifiers and heat exchange devices, etc. Again, in an ambulatory setting and in a setting where most people are operating with significantly, limited gas flows, most people aren't operating with tremendous amounts of gas flows in intubated, or LMA type of a case. So I don't know that your ability to lose that much through evaporation is as big a deal as what people seem to think it is. Because in reality, the amount of actual heat loss, I'm not talking about fluid loss, I'm talking about heat loss, is pretty minimal. Convection is a huge, huge part of heat loss during anesthesia. And it can be quite substantial, especially in a laminar flow type of a situation over significant portions of the patient's body. But perhaps, and unfortunately, people don't realize that radiation, heat leaving the body as it radiates to surfaces of lower temperature, is in fact one of the biggest ways that heat loss occurs within an operating room setting. So hypothermia during general anesthesia, combination of factors. Anesthesia is going to generally cause vasodilation. It's going to generally inhibit vasoconstriction, and it's going to reduce, generally speaking, at least 20 to 30% the metabolic rate for the patient during the course of the case. And the phenomenon happens within 3 phases. And it's, I think, perhaps very much underappreciated how much heat is lost within the first hour. Because I think the thinking is that if you're talking about very short cases or very minor cases, that your heat loss, generally speaking, shouldn't be that much. That is not true. That's actually not the case. It actually is pretty significant. What's happening is that the heat from the core is being distributed out to the periphery and then being lost through the periphery. But that process of redistribution of your heat from the core body to the periphery is accounting for at least 81% of core temperature fall, and for patients who are arriving under 36 degrees Celsius. And I don't know that people truly appreciate how significant that process is and important that process is, and how quick and early on that process is. And once it's gone, it's very difficult. It takes quite a lot to get it back. It's essentially analogous to the same process as drug redistribution, causing a decrease in effects when you give induction agents or various other types of agents. That redistribution within the body tissues and the body compartments is a huge factor in the loss within the central compartment that is the problem. After that initial rapid loss, there is a slow linear reduction. I think that people generally tend to think that this is the process that is going on the whole time, and this is why it's not that big of a deal in the first hour to be all that concerned about heat loss or about the patient's temperature. It actually is very important. Once you get to 2 to 4 hours, you have basically a regular slope. It's not going to be an exponential drop anymore. It's going to be a linear drop. The slope, you can have an effect, obviously, with all sorts of different things to keep the patient warm or to prevent the loss of heat from the patient, which is probably the better way to think of it. It's not to think of it as heating the patient up. It's more to think of it as preventing the patient from losing any more heat or to lose any heat as much as possible from the beginning of the case. After that, again, in an ambulatory setting, probably not as important, but after 3 to 4 hours, that's when you get to such a drop in temperature that now the body actually, the autonomic effects will start to kick in to try to raise the core temperature or at least keep it stable. And this process will start to balance out with the metabolic heat within the core tissues. So your metabolic rate has decreased, but now you're going to create enough of a retention of heat that lowered metabolic rate will maintain your temperature at whatever that level is. It will still continue to have heat loss simply because the peripheral tissues are still going on, but it will be accounted for by the core temperature remaining constant. So this graph here, I think, sort of summarizes all of that fairly well, but also to emphasize the time scale in what we're really looking at. And why it is that even in an ambulatory setting, that we're really talking about that redistribution right at the beginning of the case. If you're not considering that in your temperature management, then you're not really taking into account that which is the most important part of temperature management in the perioperative period. So neuraxial anesthesia, local anesthesia, again, very clearly, very popular, dominant, used all the time in an ambulatory setting, neuraxial, regional. The problem is that there's still substantial temperature loss and thermal loss that occurs. Okay, now it's, there's, various ways of measuring in terms of spinal segments that you block if you're doing an epidural or a spinal or whatnot. But the important point, I think, is really at the bottom there. It is a very underappreciated point that people really don't consider when they're thinking about nerve blocks and neuraxial anesthesia. Not to say that neuraxial anesthesia or regional anesthesia is not extremely helpful in an ambulatory setting. It obviously is, but it's an underappreciated concept because the very definition, what you're doing is you are blocking for the duration of your block, the ability of the body to vasoconstrict in those tissues that you have blocked off. And so even if the patient has woken up or the patient has emerged or the patient is, coming out of their anesthesia, the goal in many cases is going to be that you want to have the block to still have some effect in order to get the patient ready to go home. But this is a problem because it will still cause temperature loss. So some risk factors, basic risk factors for hypothermia. Again, in an ambulatory setting, I don't know that prolonged surgery is probably a consideration as much. Extensive burns, maybe people are doing that on a regular basis, but probably not. Severe trauma, also probably not. Major intrafluid, intraoperative fluid shifts, probably not in an ambulatory setting. But extremes of ages and lower preoperative temperature, yeah, that's probably something that you really are going to need to take a consideration about for getting, dealing with hypothermia. So the physiologic effects of hypothermia, again, I certainly hope no one's routinely finding their patients at 33 degrees C or below, because that seems pretty problematic right off the bat. But I would point out that if you look just at 35 degrees C, okay, just at 35 degrees C, and if you're thinking about CMS requirements, it's to be 36 and above. So we're not even talking about, profound hypothermia. It's mild hypothermia. Just mild hypothermia can cause the very serious problems that you can see and can affect adversely the patient in terms of outcomes, as well as in, being ready for discharge in an ambulatory setting, which is of a supreme importance in an ambulatory setting. Pretty busy slide, but I think quite useful, because it provides a very detailed list of all those particular causes and consequences of hypothermia. The increased, energy expenditure, the shivering, the oxygen consumption. I think everybody's heard that in terms of increased cardiac events. Those are all important considerations. But what I would really focus on for an ambulatory perspective is that reduced medication metabolism with increased duration of action. This has been shown in a host of different medications, okay? But specifically, the benzodiazepines, the opiates, and specifically the muscle relaxants have been shown to be prolonged in their level of action and in their reduction in metabolism because of temperature. That's well established. That's not, a theoretical consideration. That's a real important consideration. And that's going to cause issues with turnover, issues with getting patients out of the recovery area, which are of supreme importance for an ambulatory setting. So how do we maintain normothermia? Why do we want to maintain normothermia? Because of all of these real legitimate benefits of normothermia. These are things that have absolutely been established. These are things that have been studied and have been looked at, and they absolutely have been found to be important. Even mild hypothermia has been associated with, although I wouldn't say that the data is as robust as it is for some other aspects of patient discharge and patient management. The data is fairly good in terms of saying that even mild hypothermia is associated with significantly prolonged PACU recovery room discharge times. I mean, that's just true. Risk of infection. Again, not necessarily, hopefully, as big a deal in an ambulatory setting, but the important consideration here would be the consideration of if the patient has to come back to the hospital or has to be admitted after a procedure that would otherwise be an ambulatory procedure. That's a pretty important consideration, because that's a pretty big deal if that happens at your facility. That's something that people are really going to care about, and there is solid evidence that being hypothermic increases their risk of infections, increases the risk of, in this case, hospital duration. Now, just to keep in mind, when I'm talking about PACU and recovery room times and discharge, you might say, well, you're only talking about hospital duration in days here, so that, why do I care about that if we're talking about 2 hours or an hour or 30 minutes in recovery? You care about that not because there is a plethora of studies out there that are looking at finding those sorts of numbers in terms of hypothermic patients staying longer in PACU and recovery. There are studies that have found that, but I would argue that it becomes much more difficult to get that sort of data at that granular level when you're trying to look at, increments of 10 minutes, increments of 15 minutes, and what you start to get is an Hawthorne effect of you're clearly looking at this patient and you're keeping them quote unquote warm, and this other patient you're not doing anything to warm them up. So it becomes very difficult to make solid, in my opinion, interpretations about those sorts of considerations. But I don't know that that means that the data isn't useful for understanding that component of ambulatory management. By the same token, I don't know that in an ambulatory setting, you're talking about hundreds and hundreds and hundreds of cc's of blood loss. But the point here is not that that's, an everyday, every patient consideration. The point is that it really does have a significant impact on coagulation and by extension, blood loss during a surgery. And so this is a well-known thing. And it's only, as it's right up there in front of you, is 0.5 degrees Celsius difference. That's it. That's not that much. It just isn't. And so when you think about it in that context, when you think about it in the context of readmission or having to be admitted when the plan was not for the patient to be admitted, that's a very important consideration. It's the same sort of thing with the transfusion here. So the ASA, there are clear guidelines, clear standards, CMS, there's clear, skip guidelines, 36 degrees C and all that of it should be, measured or reliably measured or estimated in most patients, given general anesthesia for more than 30 minutes. So I guess, the question would be is sort of, at what level should you be measuring temperature in every patient, or you should be measuring in only a select group of patients? In reality, I think the evidence would tend to show that you should be measuring it in probably in every single patient. And the reason for that is not because it's necessarily going to go up or down a significant amount, but because the level of hypothermia that we're talking about is so mild that you want to be on top of that as early on as you possibly can, if that's going to help with getting the patient discharged that much faster. So where are you going to monitor your temperature? Something more basic. So many people are wanting to just put it on the skin surface or put it in the axilla. The problem is those are not reliable in terms of actually giving you anything about the core temperature, which is what you really care about. That's what's important, okay? So if you look, the accuracy for any of these methods only starts to really get very good when you get to nasopharyngeal, esophageal, bladder, etc. So all of the other ones, you're just making assumptions and you're making sort of, guesstimates about what it is that you're measuring, at that particular site and extrapolating that to what may or may not be going on within the central core. And so that's what I would focus on in terms of trying to get an accurate temperature, because if you don't know where you've been, then you really don't know where you're going. And so if you're only measuring temperature from a very low accuracy area, or you're alternating ways you're measuring temperature on a regular basis, then it's essentially just a random number generator. And you can just put in, if you want to, it becomes a Rorschach test of temperature. And all you want to do is you want to see a number that looks right. I don't know that that's the appropriate way to go with, managing these sorts of things if the intent is to actually get the patient to a solid, good core temperature to maximize the benefits of that. achieving normothermia. So we got to separate it into 3 phases. Everybody focuses on the intraoperative phase, which is where the focus should be. I'm not suggesting it isn't, but the preoperative phase and the postoperative phase are actually pretty important as well. It's just we kind of tend to think only of intraoperative and perhaps only in the wrong direction. So some various cutaneous active warming devices, right? So you got all sorts of different things. You got the circulating water mattresses, which again, they are used in a lot of places, and they have been utilized in a lot of different ways. They certainly may make you feel better, but they really don't have a great deal of evidence about how well they are able to actually increase the patient's core body temperature. You got circulating water garments. These are, in my opinion, more of a research sort of a setting. I know that there are commercial devices, there are commercial products and places and things that use them. But in terms of actual everyday, most ambulatory settings, what you're really looking at are the forced air warmers. That's where the money is. That's where most people focus on, which is probably why there is perhaps a controversial way or consideration with forced air warmers. Is this idea of a forced air warmer, essentially, a bear hugger, et cetera, where you have a mattress or an air-filled tube or just any sort of a blanket that has air that's flowing through it and over the patient to warm them up. There is, beyond the scope of this presentation, not to go into it too deep, there are considerations and concerns about forced air warmers, possibly having issues with contamination and contaminating surgical sites. I'm not going to get into that. I would rather focus on the fact that they are efficient, they are effective, they do work. Now, the problem with the studies that would look at forced air warmers and compare them to just OR operating room temperature is that the problem is that even within those studies, if you look at actual operating room temperature, even when they don't use forced air warmers, if it's at a certain level, it's kind of close to the forced air warmer. So pre-operative, you can measure the patient's temperature as soon as they come in. That tends to be a standard. Warm the blankets, warm air. I personally like to always set the room to 24 degrees Celsius. I certainly have had a lot of discussions about that, and have had a lot of interesting interactions about that. 24 is only 75 degrees Fahrenheit. That's really just room temperature, but besides the point. So trying to get that up there, you want to get them, try to get the core temperature, as close to above 36 and try to keep it there, because as I've already discussed, distribution is the biggest loss of heat right off the bat. And you're going to lose a tremendous amount of heat through radiation. So the lower the room temperature is, the more heat you're going to end up losing. And so you have to keep that in mind, very much in mind. Forced air warmers, I would go to the highest setting, but 40 degrees C seems like a good setting to go to. Intraoperative fluids and irrigation, there's some references there that refer to, specifically in, operations like TURPs and whatnot with bladder irrigation, that this is a very effective way to help with keeping patients warm. So one of the considerations that is often brought up is the ability for people to work and the comfort level of people working in an environment with elevated temperature. But again, to go back to my point earlier, 24 degrees C is only 75 degrees Fahrenheit. That is room temperature. And so when you think about it in that perspective, There have been several studies that have looked at this. Two of the better ones are right there, but basically you don't have a decrease in your performance at these various temperatures. Okay, it's not going to hurt anybody. Now, what's going to happen is people are going to complain more. That's true. But I think if you're considering a case or a situation where you have rapid room turnover in multiple cases in a day, my personal opinion is that keeping the room warm is probably the best, most efficient way to keep patients warm as you go through the day and as you go through the cases, in my opinion. There's some fluid warming devices. Those are, very interesting. But the point being is that fluid warming is, in an ambulatory setting, so minor an effect that it's not really something you should consider in terms of intravenous fluid, because your volumes that you are typically giving are so low that it's not actually going to have a negative impact on the patient's core temperature. I'm not saying that you should give them ice cold fluid, but what I'm saying is that even warming up the fluid, because the volume is so low, it doesn't really have that big of an impact. In the post-operative phase, in recovery, I don't understand why people do it, but patients should be covered and should be, and I'm not certain why we can only use the bear hugger or the forced air warmer in the operating room. I don't think there's any reason you can't use it in the PACU or recovery. And in fact, I wish, that was more of the standard. But those are considerations to keep in mind. So control and management of body core temperature during the perioperative period, very important, can lead to some very serious potential complications, but perhaps more importantly is that in an ambulatory setting can delay discharge from PACU and recovery, and maintaining normothermia, again, as a CMS skip guideline, is a priority, and by extension should be a priority for the reasons of regulatory compliance as well as reimbursement, but most importantly because of the science behind why it's beneficial for the patient. So with that, those are the references, and that would conclude this presentation.
All right. Well, thank you, Dr. Hendricks. That was a very informative talk. What we'll do now is I'm going to take questions from the audience, so you can submit them again by that question box or that chat box. I've got some that I'll start with. So my first question, Dr. Hendricks, is let's say I'm unable to convince the operating room, and in my case, it's often not the surgeon I'm convincing, it's the operating room nurses.
You're preaching to the choir.
Yeah. They won't let me raise the room temperature. What's the most effective intervention or to implement to warm the patient?
Well, in a setting where they're not willing to operate by, so there's, the AORN guidelines for intraoperative temperature, there's Joint Commission guidelines, there's various other guidelines that would tell you that these are the ranges as which the operating room temperature should be. It's amazing how many times I walk in, and believe me, I love a cold operating room, me personally. But again, I'm not the one having surgery, so it probably isn't about my comfort. But with that said, it amazes me how many times I walk in and I almost think that I can see my breath when I exhale because it's so cold. So if there's no room to budge on moving the intraoperative temperature, which, believe me, I understand. I get it. I believe me, I have had that fight so many times. Yeah. So at that point, I would say that your best bet is going to be the forced air warmer. As many as possible, as much as possible, as high a temperature as you can go, because that's where it's at. If you're talking about an ambulatory setting, Now, if we're talking about bigger surgeries, larger surgeries, more open surgeries, there's some other things you can work with. But in terms of just your basic, less than 2-hour case, I mean, it's got to be the forced air warmer. And in that setting, really, the pre-warming probably is even more important, because what you're really most concerned about, again, is the redistribution at the start of the case.
Okay. Also have a question about cost concerns. So what are the cost concerns with keeping anesthetic sites at higher temperatures than they've really been kept historically?
Yeah, that's a very interesting one, because it implies, and I've heard this same discussion from perioperative managers, from nursing supervisors, from hospital administration, about, are we, is it worth the extra money in their mind to keep the operating room, if we're just talking about operating room temperature, at a higher temperature? The problem with that sort of thinking is several. The reality is the operating room itself is not thermally insulated. So if you think about within like a restaurant or something where they have a walk-in freezer, for example, it's very sealed off. And so it has a very separate cooling system from the actual building itself. So because that thermal load, that thermal deficit, as it were, within the walk-in freezer is isolated thermally from the rest of the building, that's why it's not that big of a deal to keep that place at that much lower than every other room within the building. The problem with the operating rooms is that they're very large, relatively, rooms, and by keeping them colder, in fact, the studies would suggest that you're actually wasting money by keeping them at a relatively colder temperature than trying to keep them at a temperature that is equivalent to the other rooms within the hospital or the ambulatory surgery center. Because in reality, what the HVAC system is doing within the surgical center or within the hospital is it's losing all this heat going into the OR and trying to keep every other room within the hospital at room temperature. So in fact, that's a sink that's drawing out all the heat. And so you're actually wasting money from that perspective by trying to keep one area much cooler or colder than another area, when that area you're trying to keep cooler or colder is not thermally isolated.
Okay. My next question involves around infection risk, and you kind of touched on this, but the elevated temperatures, the infection risk, particularly those interventions. I mean, I know in these orthopedic cases, particularly is where I'm hearing about, for example, joints or stuff, about the forced air warmers and the infection risk.
Yeah, the problem with that is that ends up being a case where it's far more complicated than just one factor or another. So the reality is that, yes, there might be some considerations about, quote unquote, blowing, some infectious material off of the patient or from the room into the surgical site or things of that nature. But then on the flip side of the equation, if your patients are relatively colder than what they should be, they're going to have an increased risk of infection or joint infection. So when those studies are looking at that, the problem is they're not making consideration or accounting for either effect. So in other words, if you only look at whether you had forced air warmer or no forced air warmer, but you don't actually measure the patient's temperature intra-op, post-op day one, then if you find that forced air warmers are associated with more, joint infections, that might be a conclusion you would come to. One could also come to a conclusion that the reason they were using the forced air warmer is because the room was so cold that the patient was that much colder. And that's why they were having more infections. It's a lot more complicated than it's actually presented, I think, in some articles and some discussions.
I see. Well, does anyone else have any questions? I did just have a question about having access to the slides, and you will be able to review this webinar on the SAMBA website afterwards. I've just had another question come in. What is the best argument for room temperature setting at 75 degrees when discussing with a resident or staff? So, in other words, if you're saying, I really want this temperature to be 75 degrees, what is the argument you would give them, Dr. Hendricks?
Well, I would say at that point that really what you're trying to do is to minimize the amount of heat lost at that first 30-minute hour of starting the case. Now, I grant you, you can slap, the forced air warmer on as quickly as possible and all these different things. But the reality of the case is that the first thing that happens is, the patient gets up on the OR table. Maybe they had blankets on out in pre-op. They take the blankets off. You don't have the forced air warmer on right there at induction. You induce the patient. Things happen, et cetera, et cetera, et cetera. They're prepping the patient. The point is, all of that time is time that heat is potentially being lost. And so, yes, all those forced air warmers and all the various other adjuncts one could consider to try to heat up a patient or prevent heat loss from the patient, I'm not saying that they aren't beneficial. But my point is that just because of radiation, just because of the difference in surface temperature between the patient and the room, because of that is the most important factor when you first start off the case in terms of the heat lost totally from the body. Now, the heat distribution is not really heat that's lost from the body, right? It could go back from the periphery to the core potentially, but it's not going to if it's already going to go out into the operating room because the operating room is so cold. So you can fight that very easily and not even have to have the same sort of battle at 30 minutes, an hour and a half into the case that you would have had if you had just kept the room temperature higher relatively than what it typically is kept at in most operating room settings.
Okay. What do you say? And I often hear nurses say this kind of thing, like patient will say, why is it so cold in here? And the staff will say, well, the cold temperature kills the bacteria. Is that just totally a myth? I've heard people say that.
No. I mean, certainly, certainly there would be the truth of, microbial growth tends to be lower in lower temperatures in a petri dish setting. Nobody disputes that. But the problem is that is a non sequitur and it's a red herring. It's not something that is actually important in the context of how the patient is getting an infection, a surgical site infection, or any kind of a perioperative infection in that setting. In reality, because the patient has a lower temperature, for whatever reason, their immune system is less able to fight off infection. Their skin, their lungs are less able to prevent any sort of an infection. And so that's actually the more important consideration. It is technically true that microbial growth is generally lower at lower temperatures. That's true, but that's not really relevant in the context of what we're talking about with patients and perioperative care.
I see. Great. Well, I thank everybody for joining this webinar tonight. And we appreciate it. And you can always review this webinar on the SAMBA website, even after tonight. You can always go back to it and review it later and see the slides and listen to the webinar again. Thank you, everybody.